Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientists monthly webinar series. I'm Dr. Jeff Borenstein, President and CEO of the Foundation, and your host for today's webinar. Today, Dr. Will Carpenter will present Psychotic Disorders, Current Concepts and Therapeutics. The Brain and Behavior Research Foundation is committed to alleviating the suffering caused by mental illness by awarding grants that will lead to advances and breakthroughs in scientific research. The Foundation is the largest private funder of mental health research grants. Since 1987, the Foundation has awarded more than $380 million to fund more than 5,500 grants to more than 4,500 scientists around the world. 100% of all donor contributions for research are invested in our grants to scientists who are working to find breakthroughs in disorders such as addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorder, OCD, post-traumatic stress, and schizophrenia. I'm delighted to introduce Dr. Will Carpenter. Dr. Carpenter is Professor of Psychiatry and Pharmacology at the University of Maryland School of Medicine. Dr. Carpenter is a founding member of our Scientific Council, was a Foundation Distinguished Investigator Grantee in 1996, 2001, and 2008, and the Foundation's Lieber Prize winner for Outstanding Achievement in Schizophrenia Research in 2000. Today's webinar will begin with Dr. Carpenter's presentation. This will be followed by a question and answer period. To submit your questions, please use the question tab on the control panel on your screen. Feel free to submit your questions throughout the presentation. Following the presentation, I will ask as many questions as time will allow. And now, I'm pleased to introduce Dr. Will Carpenter.
Good afternoon, everyone, or good evening or good morning if you're not in the American continents. I'm going to try to cover a fair amount of territory today relating on concepts, how these concepts are changing, and why the changes in the conceptual approaches are going to open up new targets for therapeutic discovery. So I'll talk a little bit about schizophrenia, why we need to deconstruct it, what we've learned in relationship to therapeutics from knowledge of prognosis and course, then how we get to new therapeutic targets, how these cross diagnostic boundaries, say a little bit about the movement in first episode therapeutics and in clinical high risk, which seem to be the most promising advances that we're making at the moment, and to say a word about the potential for primary prevention. These pictures are where I want to start the story. Mayo Kraepelin gave us dementia precox and manic depressive psychoses. These two categories have been fundamental and still are in the organization. For example, in DSM-V, and Bloiler is the one who gave us the term schizophrenia. What I want to emphasize, though, is that Kraepelin said that the two core pathologies were the dissociative or disorganization of thought type of pathology that Bloiler had used in coining the term schizophrenia, and the weakening of the well springs of volition, which today we generally refer to as negative symptoms. So they pointed to different components of it. This was followed in the 1950s and 60s with an extremely influential concept of nuclear schizophrenia, where Kurt Schneider had posited that certain symptoms, and you see them listed here, special symptoms would mean the presence of schizophrenia and could be used to discriminate between true schizophrenia and pseudo-schizophrenia. It was thought at the time that this might help address problems that were perceived with an overdiagnosis of schizophrenia in some countries like the United States. And these became very influential in DSM-3 even though at the time we had done the only empirical study evaluating these symptoms in relationship to the course of illness, we being John Bartko and John Strauss. John Strauss also a member of the Brain and Behavior Research Foundation Scientific Council. And we found two things that were of interest. One is that these specialized symptoms were observed in other disorders, were not restricted to schizophrenia. And if you subdivided broadly based schizophrenia diagnosis into patients who had first-rank symptoms and those who did not, it did not make any difference in terms of the developmental history or the course and outcome of the illness. So the fundamental things that made it so influential, we found simply were not the case. What I want you to notice here, though, is that there's a conceptual shift from Kraepelin and Bloiler, who emphasized disorganization of thought and negative symptoms, to Schneider, which these are reality distortion symptoms, quite different from the disorganization of thought and the negative symptoms. So the work we did then, this was part of the International Pilot Study of Schizophrenia back in the late 60s and early 70s. If schizophrenia cannot be identified as a specific disease entity and has the status of a clinical syndrome, then what are the components of that syndrome that would make meritorious targets for discovery? So we argued that there were at least these 6 components, each different from the other. You're seeing them on the screen as disorder of content of thought and perception. The Schneiderian symptoms would go there. Disorders of affect, like restricted emotional experience and expression, negative symptoms would go there. Disorders of personal relationships, there's a lot of pathology that's observed in the interpersonal context that is not captured adequately in these other frameworks. Disorders of form of speech and thought, the disorganization of thought, the motor behaviors, and a lack of insight. And we argued that each of these is an important discovery target in schizophrenia, did not need to be unique to schizophrenia, but was important in schizophrenia. And we'd shown that individual patients would vary one to the other in which aspects were being manifest. And these two workers, Peralta and Cuesta, did very nice psychopathology work in Spain. This was published in 2001. And they found also similar symptoms and added the mania and the excitement components to what we had observed. And these two studies formed the basis for a movement in DSM-V, which was intended as a real paradigm shift from thinking of schizophrenia as a specific disease entity to recognizing it as a clinical syndrome, and then saying that there are various components. If you have a psychotic disorder, not just schizophrenia, but a psychotic disorder, you need to know the nature of the cognitive pathology in the individual and delusions, hallucinations, disorganization of thought. You'll see them pop on the screen here. So these appear in DSM-5 in a drop-down menu, and the proposition is that if you're making a psychotic diagnosis, the individual needs to be evaluated on a lot of things, but for sure includes these dimensions. These are likely to be influential as the regulatory bodies, such as the FDA, when they're considering approving a compound. So far, they approve it for schizophrenia because there's a consensus in the field that schizophrenia is a disorder that merits treatment. Here, the paradigm would shift to a number of pathologies different from each other that might have different therapeutic responsiveness or responsive to different types of therapeutic intervention, and that these could be indications in and of themselves. And this fits what clinicians with a patient have to treat these components. You don't treat schizophrenia per se, you treat the components that are available, are accessible in the individual you're evaluating. And of course, there are a lot of other things you could add to this list: suicide, aggression, stress reactivity, anxiety, sleep disturbance, obsessive-compulsive symptoms, and the list could be longer. So one hope is that our field will move away from developing treatments for schizophrenia, given the limitations that it has and the lack of validity, since it's not a specific disease but has multiple components, and move toward these targets. And another movement is toward thinking of functional targets, not just pathophysiology, but functional targets as for therapeutic development. Here I've listed 4, but easy to make the list much longer. So prognosis and course. In studies we did back then, we did see that, of course, the course was very heterogeneous. People with a diagnosis of schizophrenia vary tremendously between some who do very, very well, some who have a long-lasting, stably ill, some have episodic course. But what we found was that the prediction of course was seated not in the psychotic symptoms that were being manifest, but in the developmental history. So if you want to predict a poor occupational outcome, the best predictors were the occupational competence prior to the first onset of psychosis. If you want to predict the social course of the illness, it's the developmental social history that was the best predictor. And each of these domains seemed to have its own predictive validity and were not robustly associated with the nature of the psychotic symptoms per se. And this would suggest that from the developmental history, we can identify other domains that would be relevant to developmental pathology and present potential targets for earlier intervention and for therapeutic purposes. Quick word about the general therapeutic issues. One is the necessity of a biopsychosocial medical model. Reductionism at any level limits our ability to expand therapeutic implications of discovery. And the biopsychosocial does not mean that you develop drugs to treat the biologic component and cognitive behavioral therapy to treat psychological component and social therapy for social. It means that in a general systems arrangement, you need to understand at each level of functioning the effect that your treatments have. So a treatment that's introduced at the psychological level, if it doesn't affect the brain, it's not going to affect the person. And its effects need to be understood at the social level, the psychological level, and the biological level. And that's the implication of the medical model. We think that too often people have had a narrow and reductionistic approach to thinking about the role of treatment in a broad view of the pathology of schizophrenia. Integrative therapies, this is it's self-evident that we have multiple therapies that have efficacy evidence, that these need to be integrated at the individual level. And this is a problem, particularly in the United States, maybe in many other places, but our system of care, most people with schizophrenia are not treated in settings that have expertise in the full range of effective treatments, and they're not funded and operated in a way that you can actually integrate the different treatments at the individual patient level. And it's very clear, particularly work from some of the Scandinavian countries and some of the other European settings, that integrating the different therapeutic techniques is more effective in altering the course of schizophrenia. The personalized medicine and individualized treatment comment here is, of course, there's a big push internationally and across all diseases for more personalized medicine. The big problem we have is that at the pharmacologic level is that the drugs that are approved for schizophrenia all share the same mechanism. So we don't need to look at different genetic makeups to predict which drug will be most effective for the individual because they're operating through the same mechanism. As we get more novel treatments, there'll be a greater chance of using individualized information to fit a treatment approach with the individual treatment. The other part of being individualized are the things that I've pointed out, that our targets for treatment include many areas of psychopathology and are not limited to a few areas like the psychotic manifestations per se. So current issues, there are major unmet therapeutic needs. The pseudospecificity refers to it having become clear that for much of the psychopathology associated with schizophrenia, it will not be specific to schizophrenia. So developing treatments where we understand how they're effective across disorders in the patients who are manifesting a similar pathologic mechanism. And the novel mechanism issue is one of the things that has basically driven large pharmaceutical industry away from trying to discover drugs for psychotic illnesses. That is, we cannot provide specific mechanisms for the pathophysiology, that is, the causative factors. And the pharmaceutical industry is very much poised toward using knowledge of what's causing illness as a basis for developing drugs. That, of course, is very rational, but it's problematic when we're not able to provide the specific etiological pathophysiologic information needed. So we need to understand, and there's a lot of investment now in trying to understand mechanisms of the pathophysiology. But for treatment development, it may also be focused on common final pathways, on compensatory pathways, on resiliency factors. So this is to argue that we need to broaden therapeutic discovery well beyond concepts of the pathophysiology per se, to take advantage of other ways that you can modify the symptomatic expression of illness and the dysfunctions that are associated with it. And I just tucked motor in here for a side comment, which is the motor abnormalities have been associated with schizophrenia. They lend themselves to an understanding at the level of the brain physiology that's involved. These might produce novel concepts for therapeutic development, but have not been put forward in that regard by pharmaceutical industry. And it seems that our attention to the motor abnormalities have been too much based on adverse effect of therapeutic drugs like tardive dyskinesia and the extrapyramidal symptoms that are common, and not enough with the number of motor abnormalities that might give us leads for therapeutic discovery. There is a consensus on unmet therapeutic needs that the top of the list is impaired cognition and the negative symptoms. And I'll say just a word about that in that regard. The negative symptoms, not all patients with schizophrenia have negative symptoms being caused by their disease pathology, but many do, and this is highly associated with the functional outcome. It involves diminished expression of emotion, diminished verbal output, and another factor is the anhedonia, the diminished experience of pleasure, diminished interest, diminished social drive. The other factor, the cognition impairments, which are very common in persons with a diagnosis of schizophrenia, tends to start well in advance of the psychotic components of the illness per se. If there's a deterioration in cognition, it mainly occurs before psychosis begins and tends to be more a long-lasting trait after that, not a continuous downhill picture. This slide lists some of the, in neuropsychological testing, some of the measurements that are used, and it just shows that there's a medium impairment in groups of people with schizophrenia compared to control groups, that the degree of impairment is highly associated with the functional outcome in the individual. And there is a lot of variability, so that you will have patients with schizophrenia who are in the normal range with cognition, others that are more severely damaged. But this, to date, we have not developed any effective pharmacologic treatment. And a problem with the animal models are that compounds that can improve cognition in animal models have not proven to have validity for predicting it in the human. One last word on psychopathology concepts. There are several different ways that are being explored now. The hierarchical topology of psychosis is just an analytic method to try to better understand how psychopathology is organized, arguing that our current diagnostic manuals, the nosology that's represented there, is not capturing the spectra and how different pathologic components go together. This will probably refine our assessment of psychopathology and help us understand more about the relationship between components of psychopathology. The extended psychosis phenotype, Jim Van Oss is the champion of this. This would say that psychotic experiences are very common. They're common in the population and in a number of disorders, that it would be useful in his view if we dropped terms like schizophrenia and referred to a broad range of psychotic conditions as an extended psychosis phenotype. The advantage of doing that, some would argue, advantages in terms of stigma and advantages in terms of not misunderstanding implications of the disorders, because the implications may not fit with the individual. But for treatment development, it would be clear that you have to identify specific elements of pathology and treat them in a dimensional framework. I don't know that there's a practical future for the extended psychosis phenotype, but it gives strong emphasis to looking at specific areas of pathology on a dimensional basis. In a few minutes, I'll give an example from the burn, looking at brain systems involved in language, emotion, and motor as fundamental in schizophrenia, and how they identify different areas of the brain with each. So this diagram is just simply to illustrate the point that there's emotional dysregulation that the burn group feels is central to understanding schizophrenia, and brain circuitry that involves the limbic system that you see in blue is quite distinct from circuitry that involves language and circuitry that involves the motor impairments. This type of work, and this is a direction that so much of the imaging work that is being done now may lead to, identifying brain networks, understanding which ones are differentially related to specific aspects of pathology. And if you know the network, then it's possible to conceptualize how you could modify activity in that network with a potential therapeutic benefit, and how you would measure whether that you're achieving that in the individual, and for that matter, using the imaging to identify the individuals that would be most likely to be responsive. You may have heard something about the research domains criteria that about 10 years ago was put forward by the National Institute of Mental Health. The hope was that this would address an aspect of the sluggishness of developing a neurobiological understanding of our disorders. The criticism of existing disorders is the one that I've been making, that they're heterogeneous syndromes and are not a good source of targets for therapeutic discovery. The research domain criteria is aimed at using behavioral constructs that have a known neural circuit as a starting point for the exploration of pathophysiology in the brain. And here you would see examples of these dimensions. This, by the way, this is not a diagnostic system. It's not for application clinically with humans, but it's to say that investigators can think across diagnostic boundaries, can think of specific domains of pathology, for example, negative symptoms that might be involved in impairments in positive valence, like the capacity to experience reward, to experience pleasure. And that if you start with something that's known about the neural basis for the phenomena, it may increase the likelihood that we make discoveries that become clinically applicable as we make the movement from these behavioral constructs back into the symptomatic behaviors that clinicians have to treat. So that's an experiment for generating information, hopefully accelerating information about the neurobiology underlying symptom complexities in the psychotic illnesses. New directions in therapeutic discovery. Well, genetics, and of course there's massive genetic data now for therapeutic discovery. It's very challenging because it's evident that we do not have a small number of powerful genetic associations, but we're dealing with a large number of genetic contributions, that these are vary from individual, and that will all involve alleles that are commonplace in the non-ill population. But what can be done with bioinformatics is to get information from the genetic information as to the neural circuits that they're involved in. And if they identify involved neural circuits, there's a chance to identify molecular targets for pharmacologic development. The brain imaging will provide a lot of information on brain networks, how these brain networks deviate in relationship to psychopathology, and provide targets for therapeutic intervention, and may at the same time provide a way to indicate which patients are most likely to develop from an intervention at a particular network target. Focusing on unmet needs may accelerate our discovery. Just a quick personal complaint, chlorpromazine was introduced over 60 years ago. Most of the approved drugs that have come on the market that are relevant to schizophrenia still use the same fundamental mechanism, tend to have very different patterns of side effects, but similar pattern of therapeutic effects. Clozapine is the one that's been established as being somewhat superior in the more difficult to treat cases. But this is basically saying that our focus has been so extensively on the psychotic component and relapse prevention that we have made pharmacologically virtually no progress on the unmet needs. The psychosocial interventions and cognitive interventions have been much better at identifying specific targets other than psychotic targets and trying to develop treatments that are relevant to them. And then the hope for new discoveries coming from programs like the research domains criteria. The synopsis is the one that I showed you with the three psychopathologists that are identified with three different neural circuits, and the way we may come to have a better understanding of the organization of psychopathology. This is an old slide that Gunn von Thacker, when he was with us at the Maryland Psychiatric Research Center, gave me probably almost 30 years ago. So you can ignore some of the words because they're out of date, but it makes the point that is still at the heart of what I'm trying to say about future discovery for therapeutics, that schizophrenia is like a black box with individuals in it varying tremendously one to the other. That there are subdivisions, and this one is based on phenotypes like sensory gating phenomena, smooth pursuit, eye movement, disinhibition. But if you take these as just representing different phenotypes that are associated with schizophrenia, but any individual with schizophrenia does not have all of these present, that these phenotypes may help you have a better understanding of risk factors that are associated with the disease, that these may point to molecular targets, that if you have molecular targets, you can formulate, and the illustration here is for drug discovery, a drug. But most drugs that have been introduced are tested back in the black box of schizophrenia. Here, the implication is that you would know if it was developed based on information about disinhibition pathology. If that's the source of the development, you would want to test it in patients from the black box who actually have this phenomena. So this is the style of thinking that we're trying to use with the different deconstruction models for schizophrenia, and a way to identify individuals that would be relevant for testing a therapeutic development. So I've said that we've had very modest advances in drug and psychosocial treatments, that emphasis on integration, multiple clinical targets, and individualized treatment is well established in principle and needs to be better established in actual clinical practice. The early recognition and treatment of first episode psychosis, which I'll touch on in a moment, is one of the terrific advances that appears set to make a substantial difference in the long-term course of the illness, and thinking about across diagnostic boundaries and working with new paradigms for discovery. So now a few words on the first episode psychosis. There's a lot of evidence that how long psychosis goes untreated is associated with a worse course of illness in the long run. Identifying people very early in treatment will also have different implications for how pharmacotherapy is used. It seems very important, the programs that have been testing this, to engage significant others, principally family members if it's young cases, in educational and social support, an emphasis on resiliency and compensatory mechanisms, working out specific therapies for the specific things wrong with the individual, like sleep disturbance or anxiety, and integrating these treatments. So this can be done in first episode programs. Sorry, I jumped forward a little too quickly. And there's substantial demonstration that this can make an important difference in the application of therapies, and that it appears to have fairly good evidence that they can make a difference in functional outcome, probably in course of illness. It's not yet clear that it will make a difference in exacerbation or relapse rates or rehospitalization rates, but the hypothesis that it should make that difference is rather strong. And the studies that have shown the benefits of the first episode interventions have not yet shown whether those benefits are sustained over the years. They are sustained in studies for 1 and 2 years, but it's not clear that the benefits would be sustained over the life course of the illness for the individual. So I think this is the main thing that has happened in our field that is poised to make a difference in the onset and course of schizophrenia. And that is, and I've shown pictures here of Alison Young and Patrick McGorry in Australia, who have pioneered in the development of this. This is to take information that we know in the developmental history of people with schizophrenia, and can think about this as a schizophrenia prodrome. People who are having psychotic-like experiences and find these experiences distressing or interfering with function, so they qualify as a clinical case, but they've never fully developed psychosis. Tom McGlashan at Yale, who was a consultant to the DSM-V group when we laid out criteria for an attenuated psychotic syndrome, it would be explicit that this is a syndrome. No one thinks that this is just purely schizophrenia, but it is identifying people who have a substantial increase in their vulnerability for developing a psychotic illness, while at the time they come into clinical care, they already merit clinical care because of lower level psychotic symptoms and the experience of distress. And these are the kind of symptoms. They can have hallucinations, disorganized speech, delusions, but their insight remains intact. The hallucinations they may experience, but they think their mind is playing tricks on them. They get uncertain. They may have been in a conversation with someone and then get uncertain about whether that actually took place or not. A number of kind of weak psychotic-like experiences that help identify the group. I'm going to skip the rest of these criteria, but they are available on the slides if you want to review them. It of course means they're not already psychotic, and it's not better explained by another disorder. The number of groups now across the globe have identified clinical high-risk patients. It's been validated at the level of a clinical syndrome in that distress, dysfunction, there's alterations in gray matter and white matter in the brain, there are electrophysiologic indicators that are associated with schizophrenia that tend to be found in a group of clinical high-risk patients, cognition impairment, sometimes negative symptoms, and the rate of transition to psychosis suggests that it's very successful at identifying people at risk, although the majority of people identified will not actually progress to a full psychosis. And when they progress, it tends to be, and this just shows that, if they progress to a full psychosis, in most cases it's turned out to be in the schizophrenia spectrum, but there are also bipolar or mood disorders with psychosis or other psychoses. We need a lot more evidence from clinical trials, but of the ones that have been done, compared to treatment as usual, which may be fairly effective in these early states, if you add cognitive behavioral therapy, there's a fairly substantial reduction in the likelihood that over the next 18 months or so that the person will actually develop full psychosis. So it would appear that it's a group that we already have interventions that can reduce the likelihood of progressing to full psychosis. And the ones who are not on the path to psychosis are still experiencing anxiety, depression, other symptoms that merit clinical care. And there'll be a lot of attention to therapeutic mechanisms that are much more likely to be at the compensatory resiliency and the positive psychiatry framework than in the pharmacologic treatment. It's set in very targeted ways unless the symptoms progress in a way that full psychosis is emerging. So the point there, and again, there are centers around the globe that are being set up. We don't know yet how much it's genuine secondary prevention of psychosis or delaying of psychosis. And we don't know how much difference it'll make in the long-term course. But this is a very promising area. And of course, throughout medicine, detecting illness early and intervening early is just a guiding principle. So this has been a nice, fairly recent development in the field that seems very promising. I want to finally close by mentioning the potential for primary prevention. And this is just referring to work from a Colorado group, Ross and colleagues, the pictures of Bob Friedman. But they had learned a lot about a phenotype that's based on a sensory gating phenomena that can be measured, that's abnormal in many people with schizophrenia, and tends to run in families of persons with schizophrenia. And they had a hypothesis of how choline can activate the development of this reflex. The paradigm is fairly simple. If you hear two identical sounds extremely close together, 500 milliseconds, for example, your brain tends to react less to the second one than the first. That reflex is not present or is impaired in a lot of people with schizophrenia and tends to run in families. So, and Friedman and all have found gene associations with it. And what they did was to administer placebo or a precursor of choline during the gestational phase with pregnant women, randomly assigning them, and finding out that, first of all, that if they received the choline, the reflex matured more quickly in the infants. And if they looked at 40 months later, what this shows is that the child behavioral checklist that picks up on a number of potentially symptomatic areas in the developing offspring, that there was a substantial difference and advantage to having received the choline supplements. And if you looked at the hypothesized genotype that was most vulnerable, a very robust difference between the placebo and the choline effect on measurements at 40 months. So this would be an example. It doesn't prove that this is going to reduce the incidence of schizophrenia, but it would be an example of a benign treatment that might have some general benefits during pregnancy anyhow, that you might be able to identify which pregnant women would profit most from it, and it might have the potential to lead to a reduction in the development of psychopathology. Okay, so just a quick view of where I think we are at the current time. We've got a lot of data upon which we can propose primary prevention of vulnerability. We think about the vulnerability being vulnerability probably for a number of different disorders, not specific for one, but it's very challenging to move forward with the primary prevention. I'm hoping for progress on that in the near future. But we are learning a lot about how to recognize a vulnerability stage and how to treat what's actually wrong with the people when they get to that vulnerability stage before some of them progress to a full psychosis, with evidence that we can do secondary prevention of psychosis, either delay or prevention of it, and to have a beneficial effect, tertiary prevention on functional decline. So this represents, I think, at the moment, our best chance to make a substantial step forward in our therapeutics. This will have the effect for those who do go on to a full psychosis of sharply reducing the amount of time of untreated psychosis. Thinking about drug discovery, I think it'll be exciting as the FDA and other regulatory bodies move to a new concept, so that they realize that for our psychotic disorders and many other mental disorders, that they will need to develop indications for the psychopathology rather than indications for the clinical syndrome. And the FDA is already engaged in considerations and discussions with issues like, is anhedonia a potential target for treatment? If so, which conditions would it apply to? Would we have to see how changing anhedonia changes the person's ability to experience or function in a normative way? But if the FDA moves to these new concepts, I believe that it will bring device makers and pharmaceutical industry into a much broader discovery framework for therapeutic targets. The behavioral constructs will provide clinical targets. I think that's very, very likely, starting with a behavioral construct and a neural system that underlies it. We'll get a lot more information on what affects that neural system and be able to begin testing treatments that are based on that information with the clinical targets that relate to the behavioral constructs. The basic science of mechanisms, mostly preclinical work with animal models. The animal models will get much more specific on an attribute rather than trying to capture a fuller picture of a nosologic entity, of a diagnostic entity. And with luck, we'll know a lot more about mechanisms that can drive the specifics of a large number of psychopathology traits rather than trying to organize it just into the clinical syndrome framework. And if we do that, maybe we'll have better validity, predictive validity of the preclinical models. If we do, that'll make a huge difference in the investment that pharmaceutical companies and device makers will be willing to make coming back into the brain disorders for discovery if they have preclinical models that they can rely on to make decisions, go and no-go decisions in terms of whether they have predictive validity for a therapeutic effect. In the near future, then, animal models that predict human treatment more effectively, behavioral types that are related to the therapeutic effects, early detection and intervention, which is being set up around the globe now and is promising, moving toward primary prevention of vulnerability, and in general, broadening our therapeutic discovery to wellness discovery. So on particular things that are in the near future, transcranial stimulation, so ways to use direct and indirect current or magnetic current for transcranial stimulation is showing promise and is being focused on specific attributes. Some studies relate to, can we reduce the experience of hallucinations, auditory hallucinations? Can we improve negative symptoms? So preliminary studies are mixed in the evidence, but are encouraging that this type of transcranial stimulation will give us new device opportunities. We don't know where the world will go with all the new technologies and mobile devices, but studies are already showing that persons with schizophrenia are willing to use mobile devices, that the mobile devices can generate very substantial information in terms of the mobility, in terms of state of mind in the moment, are already showing that they can be effective in helping with adherence to treatment requirements. And there may be discoveries that we just cannot anticipate yet about how information from mobile devices can be used to guide therapeutic discovery. Novel compounds are being developed to test for negative symptoms. Cross our fingers that the current leaders in that will turn out to be successful as they continue their human experimentation with it. But these do get into novel mechanisms that are not the mechanisms that are involved with antipsychotic drugs treating the positive symptoms of the illness. There's an interest in special subgroups. The example that I put here is just from our own center. Deanna Kelly is interested in gliadin antibodies. So related to gluten, about 20% of people with schizophrenia have antibodies. They don't have celiac disease, but they have antibodies. And testing whether or not a gluten-free diet will have a beneficial effect in the subgroup of people who have antibodies to gliadin. And the very initial experience with that is encouraging in relationship to negative symptoms, so that a real randomized clinical trial is being done. I put exercise in a way it's obvious, but it's very late in coming as a routine aspect of how we try to improve brain health as well as the rest of physical health, with a lot of evidence that exercise may enhance compensatory and resiliency mechanisms and have a favorable effect. And keeping in mind the substantially shortened life expectancy in people with schizophrenia, there's just overwhelming health-related reasons to do that, but there may be substantial gains in terms of brain health that are related to exercise. Function-oriented therapies and the psychosocial treatments, like including supported employment that I mentioned earlier, function has been a target. This may open up new mechanism views for drug discovery and device discovery, where the actual functional outcomes are not seen simply as secondary to the symptomatic state itself, but present primary therapeutic discovery opportunities. And as I've mentioned several times, there's such a need to integrate the range of treatments that we know can be effective with persons who have schizophrenia. And the KA at the bottom is just to remind me to make a quick mention of a novel discovery type that refers to kynurenic acid, which Robbie Schwartz at our center has been a member of the scientific board at the Brain and Behavior Research Foundation, has just developed the way an enzyme that enables the brain to have more kynurenic acid than would be normal interferes with cognition. It leads to a nice rat model for it. If it turned out to lead to an effective treatment based on inhibiting the enzyme that makes kynurenic acid, if that were to be the case for cognition and schizophrenia, that would be an entirely novel mechanism and addressing an unmet need. If that were the case, of course, one would find out if that benefit generalizes. This is very, very early in the development, and there's still not a proven safe compound to use in humans for testing yet, but that would illustrate the type of mechanistic study that we hope will generate novel targets for drug development in the future. And with that, I welcome the questions and hope that this has been informative to you, and hope there are a lot of questions that we can enjoy considering together. Thank you.